guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, I just want to quickly go over familial hypocalciuric hypercalcemia, and mainly I just wanted to throw this disease in here because it is a distractor that test writers will often use to confuse you between if we have a hyperparathyroidism or if it's just familial hypocalciuric hypercalcemia. So our pathophysiology of familial hypocalciuric hypercalcemia, or FHH, is that we have an autosomal dominant mutation in our calcium sensing receptor gene. So our calcium sensing receptor gene is going to code for the calcium sensing receptor on our parathyroid glands and also in our kidneys. This is a G-coupled receptor, and the job of this receptor is to sense how much calcium is in the blood and then tell the parathyroid glands if we have too little calcium or too much calcium. Of course, we know too little calcium is going to stimulate the release of parathyroid hormone, which then will go to the kidneys, stimulating 1-alpha hydroxylase to make the active form of vitamin D. The active form of vitamin D will go to the gut and increase calcium and phosphorus absorption. It will also go to the bone, increase bone turnover, and increase calcium and phosphorus release. And then finally, the kidneys, which are controlling this pathway, are going to increase calcium absorption and phosphorus excretion, raising calcium levels and decreasing phosphorus levels. That's what happens in normal physiology. When we have this autosomal dominant defect in our calcium receptor gene, however, this means that our G-coupled calcium receptors in our kidneys and our parathyroids are going to be ineffective. Because these calcium receptors are integral for the suppression of parathyroid hormones, they're mediating some of this negative feedback that will turn off this system. When we don't have these functional receptors, then we are going to get to uncontrolled increased parathyroid hormone release and increased calcium due to the downstream effects of parathyroid hormone. This presentation is going to be hypercalcemia, and it's usually asymptomatic, so it's usually just noted on incidental blood work. And right now, you may be thinking to yourself that this sounds indistinguishable from primary hyperparathyroidism, which also occurs at our parathyroid glands, and we're going to see increased parathyroid hormone and also increased calcium. However, the key distinguishing lab value here is a decreased 24-hour urine calcium, which you will only see in FHH and not primary hyperparathyroidism. Additionally, the presentations are a little bit different in the fact that our presentation for FHH is going to be asymptomatic, whereas with primary hyperparathyroidism, you can have a lot of complications, primarily bone complications. You're not going to see those with FHH, and that is the reason with FHH, you do not actually have to treat this condition. This condition is benign, it does not require treatment, and so you should not do anything drastic, certainly not a parathyroidectomy if someone has FHH, whereas that would be on the table and that would be a consideration if we were talking about primary hyperparathyroidism. So quick recap here, FHH is a problem with this calcium sensing receptor on our parathyroid glands. Because we don't have that calcium sensing receptor active, we're not going to have any negative feedback. We're going to get increased PTH release. Increased PTH release is going to lead to increased calcium overall. The key thing that distinguishes this from primary hyperparathyroidism is the decrease in 24-hour urine calcium, and that is what you should be looking for to distinguish FHH from primary hyperparathyroidism. FHH is also going to be asymptomatic, and thus it does not require treatment. Now, how do they ask you about this on a board-style question? Well, something they might ask is, a 26-year-old woman presents for her annual physical, routine blood work reveals elevated calcium. Further testing reveals increased PTH and decreased 24-hour urine calcium. What is the most appropriate therapy for this patient's underlying condition? So our patient is asymptomatic, she has elevated PTH, and she also has decreased 24-hour urine calcium. That is a classic presentation for FHH. And because that we know that FHH is benign and also asymptomatic, this patient does not actually require intervention, and the best treatment is just observation. Now, I hope this video was helpful, and I'll see you next time.